So my name is David Etzioni, and I'm a colorectal surgeon here at the Mayo Clinic Department of Surgery here in Arizona. And I'm speaking today about a study that was published in the journal Cancer, and this is a study that I published together with a team of my co-authors and co-investigators. This is a study which looked at a cohort of approximately 6,400 Medicare patients. So these are patients in the US, aged 65 years and older, who were diagnosed and treated for rectal cancer. And the purpose of this study was to examine characteristics of the hospitals where these patients were treated and the surgeons who performed these operations. And the specific questions we asked were related to the relationship between these factors and patients' long-term survival after their treatment. In conducting this study, we counted for a broad range of patient factors, things related to the patient's age, their comorbidities, how sick they were, and the level of the tumor that they had. And our specific questions were related to whether the type of surgeon that performed the operation impacted their long-term outcome, and also whether or not the type of hospital impacted the long-term outcome. With regards to the aspects of the surgeons, we looked with very fine focus on each surgeon's operative volume, the extent to which their practice was focused on rectal cancer, and also whether or not each surgeon was board certified in one of the subspecialties of surgery, that is colorectal surgery. Within the US, these operations are actually most commonly performed by general surgeons, not by subspecialized surgeons. Looking at the hospitals, we looked specifically at the hospital volume in the treatment of rectal cancer, and also whether or not each hospital was designated by the National Cancer Institute as a comprehensive cancer center. What we found was that it really is very important to have your operation performed by a surgeon who's subspecialized in the treatment of colon and rectal cancer, because it looks like the operations performed by these surgeons go better. They go better in terms of the patients having a better long-term outcome. Also, we found that a hospital's designation as a comprehensive cancer center by the National Cancer Institute is also related to long-term survival. So the upshot of this article really is that for patients, providers, and payers who are interested in long-term outcomes, that patients are really, I think, reasonably directed to surgeons with a focused expertise in rectal cancer, and also to hospitals who have a focused expertise on cancer treatment. Sure. So in the US, virtually all surgery for rectal cancer is performed by somebody who has completed their training in general surgery. Of those surgeons, general surgeons, a small proportion of them have completed additional training in colorectal surgery. That's an additional 1-year training. So the total surgeons in the country, of the total body of general surgeons, probably less than 10% of them are subspecialized in colorectal surgery. Now, looking at major operations for rectal cancer in this country, the colorectal surgeons perform a disproportionate amount of it. Approximately 40 to 50% of surgery for rectal cancer in the US is performed by colorectal surgeons. But still, in the US, a majority of operations for rectal cancer are performed by general surgeons. The long-term survival is approximately 15 to 20% better in the hands of a colorectal surgeon compared to a general surgeon. That same difference is also seen for a National Cancer Institute designated comprehensive cancer center relative to a different kind of hospital. Despite the fact we looked at a large cohort of patients, about 6,400 patients, we were actually still quite limited in terms of figuring out the specific magnitude of these differences. For example, in the study, even though we had 6,400 patients, only about 6% of those patients were treated at a National Cancer Institute designated comprehensive cancer center. There is a problem in the US in terms of the geographic distribution of subspecialist surgeons. Subspecialist surgeons tend to be much more highly concentrated in higher density urban areas. For example, the number of colorectal specialists or subspecialists per capita is about 10 times higher in New York State than it is in Wyoming. And that really demonstrates what may be a problem in terms of patients getting access to subspecialist care. It's a very difficult problem. It's not something that the study specifically analyzed, but it is part of how the study is interpreted. Well, one of the biggest issues in taking the results of the study and translating it into a policy change is how do we direct patients? How do we try to navigate patients towards a surgeon and or a hospital where it's possible that their care might be better, their outcomes might be better, their short-term and their long-term outcomes? And that's a very tricky, very sticky political question. It's tricky because what we're actually talking about is potentially taking patients and moving them to what has been termed centers of excellence. In order to establish that type of a system, you would first have to establish some fairly strict criteria about what exactly a center of excellence is. But then the harder part is actually work with the providers, the payers, the patients to figure out the right means by which to get the patients over there. Would we potentially restrict trade amongst hospitals and surgeons who are not part of a center of excellence? These are all enormously important questions that I think will have to be hashed out in the future. But I do think that we are moving into a system where hospitals and surgeons have a more dedicated and more restricted focus of expertise, and one hospital, one surgeon doesn't necessarily fit every patient. I think the message for patients is that there really is an enormous burden that we put on patients to find the right place to have their operation. And I think a lot of times the pathways by which patients arrive at their surgeon are very informal, and they may not always serve the patient well. I think in the absence of other information that is specific to a patient, their region, and the surgeon to whom they're being referred to, I think that patients in general are best directed to cancer hospitals and cancer surgeons who have specific expertise in the disease process that they need treatment for.